Good evening, everybody, and welcome to the third of our renal kidney health series for GPs. My name's Anne-Marie Swoboda. I'm a GP and I'm the Medical Director of the GP Liaison Unit for Canberra Health Services. So before we begin this evening's session, we wish to acknowledge the traditional custodians of the land in which we're meeting, the Ngunnawal people, and we wish to acknowledge and respect their continuing culture and the contributions they make to the life of this city and this region. And we pay our respects to their elders, past, present, and emerging. And we'd also like to acknowledge any Aboriginal or Torres Strait Islander people who may be joining us for this evening's session. So this evening we should have everybody on mute, and if you could keep yourself unmuted, that will just help with keeping it running nice and smoothly. Please though, do feel free to pop your questions into the QA and chat function any time throughout the webinar. I'll be monitoring your questions and we'll be answering all of those at the very end. And we encourage you also to complete the evaluation at the end of this session. So this webinar is on prescribing in chronic kidney disease. We've had two fantastic webinars before this, one on acute kidney injury and hypertension, and then CKD last time. But this one's really important for us in general practice, and I am very pleased to welcome with me today Dr. Tom Lee Henry. So Tom's a renal physician who joined Canberra Health Services in 2024. And he's also a clinical scientist and a McCusker Research Fellow at the ANU. And he works here at Canberra Health Services in our renal clinic. So Tom, over to you.
Thank you, Anne-Marie. Okay, so I'll flick through. And there will be some cases like the other weeks sort of interspersed through here to try and keep it a bit more interesting, because this topic can get a little bit dry, but it is actually a really important one. One of my former colleagues used to say, it's not a surgeon's, you'd expect a surgeon to know how to use a scalpel, and we should probably understand how to use drugs in the same way. But it's a little bit more complicated with drugs than scalpels, I think. But the concept, I think, is a good one. So what we'll be covering is a rational approach to adjusting dose of drugs that we might need to in patients who have chronic kidney disease. And then we'll be looking at what factors are important when we're thinking about doing these sort of things. How we can individualize treatment to a given person with varying degrees of chronic kidney disease, and the limitations that exist around using estimated GFR as a way to guess what kidney function is and to make our dosing adjustments. We'll have a brief discussion about the differences between AKI and CKD, which is actually very difficult. Managing drug dosing in AKI can be really quite a lot more difficult than CKD. And then we're looking at some of the drug factors that we need to be thinking about as well. And the cases that we'll cover, we'll start off with diuretic use in CKD in a nephrotic patient or someone with a lot of proteinuria. We'll then cover trimethoprim and AKI. Anticoagulant use in CKD with a particular emphasis at the end on warfarin, which for us there's been quite a lot of development around warfarin and advanced CKD in the last sort of 5 to 10 years. And then the famous one, metformin in CKD, we'll cover too. And then there's a little bit of other things interspersed through there, including some of the sort of nuanced stuff around how reduced renal function doesn't reduce your renal clearance of drugs, but it can impact clearance of other drugs by other mechanisms too. So, and again, this kind of comes back to that drug dose adjustment for CKD. It's accepted standard of practice. It's something that we all do. It's something that we're all familiar with. Everyone's familiar with looking at dose adjustments for people as their kidney function declines. And the important thing about when we are making these dose adjustments is we want to make sure that drugs are not accumulating because they're not being cleared as kidney function declines, and therefore leading to toxicity. But the other side that we also don't often think about as well is we need to make sure that we're not under-treating people. Because drug use for patients with CKD is very common. Patients with CKD have a range of comorbid disease that we need to treat. And so we're often prescribing medications for these people, and we obviously want those to be optimally effective. And so this is a paper from 2020 that showed that as your kidney function declines through stages 1, 2, 3, and up to stage 5 CKD, just get a little pointer out there. What you can see is that there's an increasing amount of people who are having potentially risky prescribing. So, at least 34% of people with stage 5 CKD in this study were found to be prescribed something that they were contraindicated to have on the basis of their renal function, for example. And then again, another 46% of people who had a high dose of something relative to their kidney disease. And obviously that's less the case as you go back in the stages, but it kind of highlights that this is actually a very frequent problem, with the majority of people with stage 4 and 5 CKD in this study having some inappropriate prescribing. And often that's on us as renal physicians, to be honest. So, and why, I guess the next question is, why is this important? Why do we care? And one of the things that we care about here is with different drugs, there are different risks. And so if you're talking about a medication that's, in standard dosing relatively safe, like cefalexin, it's got a relatively wide therapeutic index. So that means that difference between the therapeutic dose and the toxic dose is quite broad. So you have to go a long way above therapeutic dose before you start to run into difficulties. And we refer to that here as the therapeutic index, which is that gap between where 50% of people have toxicity and 50% of people have therapeutic effect. And the wider this index is, the safer it is. It means we can go all the way out to the end of this therapeutic effect before we're running into difficulties with toxicity. And then toxicity, you need to have quite a lot higher dose, looking at this as a log scale on the bottom. And so for drugs with narrow therapeutic indices, though, we need to be a little bit more careful. And so a wide therapeutic index looks like this. We've got this nice big gap between those two dosing phenomenons. But here, where we've got a narrow therapeutic index, what we can find is that even at that 50% of people having some effect, or having effect, there's going to be people having adverse effects. And you don't have to go too far beyond that dosing interval before you start to increase that risk of people having adverse effects. Or if their kidney function drops significantly, they have an acute event on top of their chronic kidney disease, they can then tip over into this toxicity. And so the medications that we think about with narrow therapeutic indices are very commonly prescribed in CKD. So patients who are on opiates, for example, or anticoagulants, digoxin, and insulin, these are all drugs that are recognized to have low therapeutic index. And then other things like the sulfonylureas can have a narrowed therapeutic index, particularly in CKD, as their clearance diminishes. And you can see, actually, when we look across this list of medications, there's a lot of things here that we like to use pretty frequently for treating people with advanced kidney disease. On the other screen, sorry. I'm just going to shift the pointer across here. I've got it on the wrong screen. So what you can see is that we've got a whole lot of drugs here that are pretty commonly used. And these are the ones with the more serious narrow therapeutic index, where we can start to get into real difficulty. And so that kind of brings me back across to some of the basics of pharmacokinetics, because we're really talking about how the body is handling the drug here. When your kidney function declines, your ability to handle drugs, many medications, diminishes. And so what we're talking about with pharmacokinetics, just to sort of scoot back through some of the basics, is that if you're thinking about an orally administered drug, pharmacokinetics involve all these different effects: the intestinal absorption of the drug, the hepatic metabolism and clearance of that drug, if it has significant hepatic metabolism and clearance, and then the ability of that to get out of the gastrointestinal tract into the bloodstream, where it may or may not be bound to plasma proteins, because of course it's that free drug that is able to act and get into tissue sites, how that drug then distributes to tissue sites where it can reach its site of effect. And this site of effect is where we see our physiologic outcomes of drug dosing, the reason that we give these drugs in the first place, to see that outcome. And so the other side of that, though, is the amount of drug that you have in your system is not just how much you're absorbing into the bloodstream, but also how well that's then cleared by renal elimination for a large number of commonly used meds. And so what you can see here is 3 different drugs and their effect depending on how your kidney function changes. So with reducing creatinine clearance here on the bottom, heading from 150 at the end all the way down to 0, what you can see is that some drugs in a sort of idealized world, like this line in blue, is purely hepatically cleared or non-renally cleared. And therefore, it doesn't matter what your kidney function is, you're not going to have accumulation of this drug as your kidney function declines. Then there are drugs that are purely or significantly renally cleared, so that as your kidney function goes down, eventually you get to a point where if you had no kidney function at all, you'd have no clearance of that drug, and you'd be at a high risk of having accumulation and toxicity. And then you're kind of in the middle ground here in the dashed line, which is probably most drugs, where there is a degree of renal elimination, but there is a degree of hepatic elimination too. And that can vary drug to drug, person to person. And it can actually be really difficult to predict how much of a given drug in a given person is being cleared by kidney or by liver or something else. The other side of this as well is that we make our dosing decisions often based on one of 2 methods. We can look at estimated GFR, which is probably the most commonly used one, where we'll simply look at the serum creatinine. We'll take what is now the CKD-EPI equation, which provides us with that estimated GFR, and we will make an assessment of how good or bad someone's kidney function is. In the not too distant past, we used to do a Cockcroft-Gault equation as well, which is how a lot of dosing studies were originally done, where we take into a different factors, including gender and weight and lean body mass, to determine what, to try and estimate again what kidney function is doing. And we really have had this sort of tussle in recent times between which of these is actually the better measure. And so this is a 2019 paper, which unfortunately doesn't separate them both out. But what it shows you is that in your estimation of GFR, whether it be from the CKD-EPI equation or from a Cockcroft-Gault calculation, actually correlates on average reasonably well with measured GFR, where we're actually doing a gold standard test of kidney function. There is some variability, and that variability is different between the 2 tests. And we'll cover that in a minute. But really what this shows you is it doesn't really matter in many ways which one you use. They're probably most of the time very good tests, very good ways of estimating kidney function. So the other side of that, though, is we do get conflicting data. And so that same 2020 paper I showed you before actually showed that there's actually in certain instances, there are significant disagreement between dosing decisions made on one calculation, here the CKD-EPI decision making versus the Cockcroft-Gault decision making. So mostly they agreed on appropriate decisions when a dosing, it was reasonable to give a dose. Both of them agreed. But when it started to become into some of these questions about whether it was either inappropriate or in fact, frankly, contraindicated, you can see there's actually quite a lot of difference between how these 2 methods predicted which way to go. And I think that's important to recognize that this is not a clear-cut and easy decision to make in certain circumstances. And actually, one of the things that we'll kind of hopefully take away from today is that even though we're going to make a best estimate about a safe dose for people, when you're talking about people with advanced CKD, one of the most important things that we need to think about is monitoring that effect, because we're not really sure necessarily whether we're going to be over or under dosing, and so careful monitoring and attention to that's going to be key. And so from that same 2019 paper, what you can see here is that when they compared the estimated creatinine clearance, which is your Cockcroft-Gault equation, versus your estimated GFR, essentially they're very, very comparable across a lot of metrics, but the key area that they differ is on body weight. So in the obese, the estimated GFR, which is the one we get all on our pathology readouts, underestimates the GFR, which is probably a safer way of going. It's really what's saying is your kidney function is lower than it truly is. And so we're probably going to underdose people to start with, and then we can sort of inch that up as we go. With the However, in smaller people, particularly those who are very lean, it will actually overestimate GFR, and we need to be very mindful of that as well. That if we're overestimating GFR, so if we're getting a really slim 70-year-old person come in, their muscle mass is going to be relatively low, and we're going to be very careful about dosing that patient based on eGFR. And then, in terms of what does the literature say about what we should do here? The Australian Family Physician journal, and in 2013, essentially came to the conclusion that we should use Cockcroft-Gault and Cockcroft-Gault alone, and that actually, to be honest, had been our setting for a long time. But in recent times, there's been a lot more study around how closely these two things correlate, and how safe it is to potentially use the eGFR, which everyone has access to, and most people don't have time to do a Cockcroft-Gault equation in their rooms. I certainly don't. And so can we rely on these things? And certainly KDIGO, which is the Kidney Disease Improving Global Outcomes, which is one of our international conglomerates around kidney disease and the management of kidney disease. Essentially what they believe in their policy document is that the Cockcroft-Gault equation is comparable to estimated GFR by any of the commonly used methods. And in Australia now, pretty much everyone's on CKD-EPI, as it seems to be a much more accurate way of estimating GFR in general. What they say, though, is that we need to be careful around extremes of body weight. And as we were kind of talking about, therapeutic dose monitoring, therapeutic drug monitoring is important, whether we can monitor drug levels, or whether, in more often the case, because we don't have a lot of drugs for which we can do that, we monitor the pharmacodynamic effect, the effect that the drug is having on the body. And so for an example of that would be, if we're looking at using sulfonylureas in a person with advanced CKD, we don't have a lot of other options potentially. In that circumstance, we would start low, we would monitor their blood sugars, we'd be mindful that their time from starting the drug to getting peak effect is going to be delayed because of their reduced clearance. And so we're just going to get them to monitor their blood sugars a lot more closely. And if they're finding that, in fact, they're getting the blood sugars coming down too low, then we'll simply stop that drug at that point. And so this is a quick one about AKI. So we kind of see this a lot in hospital, where the problem with AKI and estimating kidney function is that the change in creatinine by definition is dynamic. And so what you're seeing is, if you look at this sort of mock-up of someone having an acute kidney injury, if you look at their creatinine here in blue and their actual GFR in red, before their AKI, nothing's really much, everything's kind of stable. But what you can see is that the real-time GFR drops substantially, and a lot more early than we see a creatinine rise. That creatinine rise is delayed, and that is problematic, because it often means that we are missing things. We often, even in hospital where we're monitoring maybe these things every day, what we'll find is that actually the AKI is already set in before we've actually recognized that it's happened, especially if it happens outside of the morning, blood taking interval. The other side of things here as well is that which you can see between, say, these 2 points here, where the creatinine's gone from, let's say, 110 to 150, that it's still rising beyond that point, but at this point we don't actually know that. And so it's very difficult to then make an assessment of what the GFR is. When I'm bothering the residents on the ward round, what I'll often say is, well, look, if someone loses both of their kidneys, what will happen to their creatinine tomorrow if it's 100 today? And the answer is, depending on body mass and lots of other things, it'll go up by 100 to 200 micromole per liter in that time. So what you might find is someone's creatinine goes from 100 to 200 in the course of 24 hours. And in some people, that may mean that they're functionally anephric at that point. But if you look at their GFR is probably going to be somewhere in the 30s. And obviously, that's the extreme example, which says that actually, really, until that creatinine hits steady state, the estimated GFR is really a meaningless number. And Outside of hospital and even in hospital, this is actually something that's very difficult to manage, because we can't actually tell what the kidney function truly is without doing silly things like timed creatinine clearances and things like that that really arguably don't add very much. But out in the community, this is even harder, because if you're seeing a rapid change in creatinine, then actually probably things are moving very, very quickly in the background in terms of their GFR. And so that makes drug dosing very difficult. And so, kind of talking of renal drug handling, if we come back to the nephron here, most renal drug handling occurs by filtration. So we get filtration here at the glomerulus. And so I've got the example of metformin up, but I'll just talk in general terms at the moment. So we can get filtration at the glomerulus, and then that filtered drug passes through the tubules until eventually out into the urine. There may also be some proximal secretion, so where we get drug out of the blood, secreted into the urinary space, and then further in the distal tubule, there may actually be reabsorption of drug. And we see similar things with creatinine. We see creatinine secreted, filtered and secreted, and to some extent potentially reabsorbed as well. And that's important because there are other drugs that interact with some of these pathways, and there are also metabolic functions of the kidney that we'll talk about as well. And so this can be reasonably predictable, but working out exactly how all these things interplay is often very, very difficult. So it's technically predictable, but it's actually really, really hard to manage in real life. And so an example here is metformin. So metformin is only about 30 to 50% filtered at the glomerulus. This is partly due to protein binding. So any drug that's protein bound won't be filtered, because it's not free to be filtered across the filtration membrane at the glomerulus. But it has quite a lot of proximal tubule secretion. We don't know if it has much distal reabsorption. Probably doesn't have very much. And so depending on how much proximal secretion you have and your serum drug levels, actually the renal clearance can be well above renal blood flow. It's well above renal clearance. So if we're talking about someone who's got a GFR of 150, which a young person might have, they might actually potentially have a clearance of metformin, 2 and 3 times above that. And that kind of shows you the importance of some of these other factors like tubular secretion. It's not purely filtration at the glomerulus that we all kind of mentally like to think that it is, but some of these other factors also are at play. And another kind of unusual example of that is actually fluconazole. So we don't really think of fluconazole as a drug with renal clearance. We think of it predominantly as being hepatically cleared, and that is actually true. But having said that, 100% of fluconazole is filtered at the glomerulus and enters the urinary space. So we don't really see any tubular secretion. There's none to be secreted at that point, to be honest, because the blood that comes from the glomerulus eventually ends up going around the peritubular capillaries of the proximal tubule. But almost all of it is reabsorbed. And so what you get is this tiny amount of renal clearance of fluconazole. But if we actually interfered with this mechanism, we would actually significantly increase renal clearance of fluconazole. It's just that we don't do that. And so it shows you that a drug that's hepatically cleared actually is hepatically cleared mostly because all that filtered drug is then reabsorbed. And the other one that's actually worth mentioning, because it's one that we don't really think about very much, is insulin. So insulin it's a protein, so we don't really think of these things as having renal clearance. But insulin is relatively small. It is filtered freely at the glomerulus, and then it is actually then taken up by the peritubular capillaries and metabolized. And so one of the functions of the kidney is actually insulin metabolism. And what we find is that because there's not just the amount that's filtered and then reabsorbed, but there's also the peritubular capillaries, the tubules also take up insulin from the blood side, not just from the luminal side. And they have this then metabolic function where they're actually breaking down insulin. And so you can actually have this really high renal clearance of insulin. And that can persist actually into really advanced GFRs. So when your GFR is less than 20, we do actually start to see this become potentially a problem. But because we're actually looking at a metabolic effect, this actually persists almost unchanged until quite advanced CKD. And it's one of those kind of cruel things, is what we find, that often people, someone's got diabetic nephropathy and they're kind of progressed to dialysis requiring CKD. Because at that point their renal clearance of their insulin has dropped, their insulin requirements massively drop as well. And so we've got these people who are now dialysis dependent, but actually need a fraction of the insulin that they were using pre-dialysis. And so it's a little bit unfortunately, one of those sort of cruel ironies. Okay, and we're going to kind of get into the cases in a mo and talk about some of these things. I'm just going to run through some of the basics here of the plasma concentration time curve, which is this thing that we all remember from medical school and beyond, where if we're looking at the level of drug in the blood against time, what we see for an orally administered drug is we've got a gap here while it's passing into the stomach, tablets being broken down, it's being then absorbed. Then we have a maximal concentration for that given dose, and that occurs at a particular time point for a given drug. We have then a half-life where half the serum concentration is lost. But then one of the important factors is the area under this curve, because that is telling us about, the area under that curve is telling us about the overall drug exposure that someone gets. And so we see this with tacrolimus, which is a drug that we use in transplant very frequently. And so if you actually measure AUC for these people, what we normally do is just measure the trough. But what we sometimes see is we have individuals who have this really high level, and then it rapidly gets cleared. And so they end up with the same trough level as someone who's got something that looks a bit more like that. The person, or someone who's even flatter, where it's kind of like this. And that person who's got this flat curve actually has overall a lot less drug exposure than someone who gets a really high peak and then it gets cleared away more rapidly. And that person with the high peak is probably at higher risk of toxicity, even though we don't see that because no one's routinely doing these tests. The way that kidney disease impacts this is in several different ways. It will impact the pharmacokinetics of drugs, so it'll reduce clearance, which will then increase half-life. But also it'll change volume of distribution in a lot of people. And that's a combination of changes to protein binding, but also we're thinking about people sort of being a little bit more wet and having a bit more edema. And that's for water-soluble drugs. There's more volume there that they have to sort of spill over into. But these people are also often more susceptible to having adverse drug effects because of their comorbid disease and because of their kidney disease. And then also they actually almost have changes to receptor function and density. And so that can also affect their pharmacodynamics. But we really mostly think about this as a kinetics problem, partly because that's where we have a lot of information, but also it's actually a lot easier to think of it like that. And we can just about get away with that most of the time. And so why this is important is this picture here. So this is a drug X example where if we look at the change in clearance of a drug, where we've got here a 10 times reduction in clearance, so it's a renally cleared drug. Someone's here with normal kidney function or thereabouts, and this person here is in advanced CKD. And with that change in clearance, we see this significant increase in half-life. And the half-life affects the drug in a couple of different ways. But the most important way is that as half-life increases, the time to reach steady state increases too. So time to steady state is that maximal average level that we'll get for a given dose over time. And that is so 4 to 5 times half-life. So you can see as half-life increases, time to steady state pushes out. And what that means is as we keep giving this drug to people, instead of it being cleared, as in this example where it's actually completely cleared each day, here it accumulates gradually. And by 4 to 5 half-lives, it's kind of reached steady state and it's kind of now here. And so this is how we end up with toxicity in patients with reduced kidney disease, where we are losing that ability to get rid of the drug in the same way as someone with normal clearance. The other thing that's important, although more of a hospital problem, is that if we're thinking about rapidly treating someone with a drug, increasing half-life drags that time out until we're going to get to that therapeutic level. And so if this was an antibiotic for sepsis, we don't want to be waiting for 4 days until we're reaching this level. If we dose reduce it, what we want to be doing is giving a loading dose to get it up to the right point. And so then we can carry from there. So we do get to our first case now. And so this is a 34-year-old woman who presents with a bit of tiredness, some edema, some frothy urine. So we're thinking proteinuria for a little while. She injured her ankle at netball and she's been on ibuprofen for a few weeks. And she went to ED. Creatinine was relatively normal, but she didn't wait for her results. She now presents with worsening edema and her creatinine has leapt up now to 240 micromole per litre, and the urine dipstick's showing a lot of protein. And so we're thinking she's probably nephrotic, and she ends up coming through, getting a renal biopsy, which shows a couple of different processes, all of which can be ibuprofen related, so we stop the ibuprofen. However, the interstitial nephritis probably needs some prednisolone, as does the FSGS, and so she had some prednisolone. We put her on some ramipril to reduce proteinuria. The rivaroxaban actually shouldn't be on here. That's for later. Get rid of that.
I wondered that.
You didn't see that. And furosemide. And so we're trying to get that furosemide in to get the fluid off. But what we find actually is over the next sort of 4 and 5 days, she's not really losing any weight or getting any fluid off. And so why would that be? And so this is a common problem that we see for patients who have significant proteinuria, where they can become relatively diuretic resistant. And there's a number of mechanisms that drive this, but one of the important ones is actually a pharmacokinetic one. So when we think about diuretics like furosemide, which is the most common one that we would use for this, it is highly protein bound. And so some of the factors that are fitting in for a patient like this we need to think about is that if they have a lot of edema, and so they've got, in fact, edema involving their gut wall, that can reduce furosemide absorption, which is already actually relatively low at about 50% of a dose. If they're taking too much salt in or they're drinking too much fluid, they can always outdo their diuretics. We can't compete with that. So that is something we are always mindful of. And we'll come back to pan-nephron blockade in a sec. But the thing we need to think about first, probably in this person, or after we take away the fluid and salt, is that furosemide actually works on the luminal side of the tubule. And so it needs to be filtered, it needs to get into the urinary space, and it needs to be freely available then to act on its receptor. And so for most people, that's not a problem because furosemide is filtered reasonably freely, it enters the urinary space, and there's nothing there to stop it working. I'll show that on the next page. If your GFR is dropped, you're going to get less filtration, so you're going to have less effect. And then if you've got a lot of protein, then I'll show you on the next slide, that starts to impede your ability of furosemide to work. And so sometimes what we need to do for these guys is something called pan-nephron blockade, where we start to shut down different parts of the nephron. We target the thick ascending limb of the loop of Henle with the furosemide, but then we start to add things on top. Because as you block the thick ascending limb, you can actually get compensatory increases in some of those other receptors. So we might start to add in things like a thiazide or a thiazide-like diuretic to start blocking things further down in the distal nephron, and then even potentially looking at things like spironolactone to block down into the collecting ducts to try and block off some of these compensatory responses too. But the first and easiest thing to do is probably increase the furosemide. And so this is what we were looking at before. The furosemide is working here. It's in person without proteinuria, it's free to bind onto these receptors, prevent reabsorption of sodium chloride and the water that goes with it. So it then results in its diuretic function. In proteinuria, we get both furosemide and serum proteins entering the urinary space. And what that means is they then interfere with furosemide's ability to bind to these receptors and do its job. And so we can overcome that. If we could reduce the proteinuria magically, that'd be great, and we can do things that will help. But really what we often have to do is overcome that by giving more drug. And so what you'll sometimes find with some of our patients is we have them on ridiculous doses of furosemide to try and work on that, especially people with advanced CKD where we're trying to get enough through the filter first, and then enough that's free from the protein binding to actually function. I mean, I have someone at the moment who's on 500 milligrams a day of furosemide, and that's just about holding them, but they do have other things going on too. So we sometimes do have to do these seemingly silly things to get effect in the setting of CKD. So it's not simply that CKD will increase your risk of toxicity, but for this woman, actually, it's reducing her ability to get efficacious result from her drug. And so to continue the case, she has good response, GFR's improved, we get the frusemide, that proteinuria is now settled, so that's all very good. But now she's got a new urinary tract infection, bit of suprapubic pain and fever, and a suspicious dipstick. And so she started on trimethoprim. And then at follow-up, sort of 5 days down the track, what we find is actually now she seems to have gone backwards. She got the serum creatinine is now jumped up, so it was probably sitting here in the probably 70s or 80s. It's now more than doubled, and now she's a little bit borderline hyperkalemic as well. And so what's going on here? Well, this is actually something we see quite a bit, and this is the effect of trimethoprim, which is a good antibiotic, but is actually also a diuretic and an inhibitor of creatinine secretion. So the hyperkalemia is actually that it's working here in the distal collecting duct, interfering with sodium-potassium exchange in the same way that we would use spironolactone or amiloride to do the same thing. It's just not as effective at doing that as these other drugs. So we do have to be mindful about hyperkalemia with trimethoprim. But what's more common actually is we see these changes in kidney function, particularly in certain demographics where someone's on trimethoprim, their GFR drops, sometimes quite precipitously. And there's the question there is what happened? Is it acute interstitial nephritis, which would be treated differently? Is there another cause of AKI, or is this simply the trimethoprim that's doing it? And so because in health, 10 to 20% of your creatinine is secreted in the proximal tubule, if you interfere with this significantly, you will reduce your clearance of creatinine and you will put up your serum creatinine and therefore reduce your GFR without actually changing glomerular filtration rate at all. And so it's one of these interesting things where the patient looks like they've had a severe kidney injury, but in fact the kidney's not injured at all. Obviously, we need to make that as a diagnosis of exclusion. But this is actually more of a problem for patients who have CKD and the elderly. And we'll get onto that actually on the next slide. But from a hyperkalemia perspective, people who are still on their ACE inhibitor, like this woman probably was, or on spironolactone, are more likely to have both of these problems. So we've looked at this in health. There's this we get at sort of 10%, 20% tubular secretion of creatinine. But as your GFR drops, your reliance on tubular secretion of creatinine to clear your creatinine in total goes up. And it can actually go as high as 50%. So that means only about half of your creatinine clearance is being done by your glomerulus, and the rest of it's coming from your proximal tubule. And this is problematic because we think of GFR as what it says, glomerular filtration rate. So if your serum creatinine is 130 and your GFR is 45, we would say, oh, well, that's consistent with someone who's got, never really exactly, but maybe about 50% loss of nephrons or something like that. But actually, it can be significantly more than that. And we are being lulled into that because, in fact, their proximal tubule is compensating so well that their clearance is up and their true GFR is lower than we can actually measure in routine clinical practice. And what that means is when we throw trimethoprim into the mix, for this person, your standard person with normal kidney function, when we throw trimethoprim in the mix, they might have a mild change in their serum creatinine levels. We're probably not even going to notice. And in fact, a lot of young people will not get a significant change really here at all. But in someone who's got CKD or they're elderly, particularly if they're sarcopenic, what we can find is actually that change, if you block off that tubular secretion, means their GFR tanks, and we get really, really worried that that's what might be driving it. Thankfully, in this situation, it's not being damaged. We simply stop the trimethoprim and it rapidly improves. Okay, so move on to case 2, which is a 67-year-old male who's sort of a bit of a standard patient, type 2 diabetes, multiple microvascular complications, and they've got the GFR now sitting around 45, significant proteinuria at 180 milligram per millimole, serum potassium's within normal range. And so they've come to our attention because they've ended up after a long haul flight presenting with symptoms of a DVT. And they don't want to monitor INR because really, let's be frank, who does? So what do we do for this person? And so when I originally did these slides, we were in a very different place. And for those who are clever, you'll notice my mistake here, where I've put the dosing interval the wrong way around for the last two DOACs. But when we look at anticoagulation, the warfarin's really attractive for someone with CKD when you look at it on the front, because it's once daily dosing. Everyone likes that. It's 100% cleared by the liver, so we shouldn't run into difficulties with kidney function, because this warfarin should be this drug out here, where it doesn't matter what your GFR is. We're going to dose you the same.
Point to the other screen.
Oh, sorry, pointing to the other screen. So so warfarin should be this black line out here, where we're not seeing that change. Doesn't matter GFR, we're not seeing a difference. And there are some nuances around that which we will touch on. But most of these other drugs, you can see they've got a combination of liver and kidney clearance. So they're going to be one of these drugs in red, and they're going to have various lines depending on how much they rely on kidney function for clearance. And so dabigatran is mostly renally cleared, so we're going to try and steer away from dabigatran. And so the question then becomes, which of these do we choose? And really, what we end up doing is, most people now actually end up using apixaban, because we've got a lot of good data around that. And so if we actually go through how we would dose adjust that. So this is the kind of sort of bare bones, how we would sort of think about this problem for a given drug in a given person, which none of us have time to do on a regular basis. But really what that is we get a history of kidney disease, we get that GFR, and we get trend. Trend because we want to make sure that GFR is stable and we're truly getting a good representation of what estimated GFR is. We're going to look through their meds, and then we're going to have a look at the risk to them from their medications. Are their ability to clear these drugs change from their reduced kidney function? And then we're going to dose adjust that. And then the other important part is we're then going to monitor that response. And so we'll touch on that on the next slide when we go through one of these dose adjustments. And then we keep further revising, because everyone's kinetics are different. Even though we know that we can make rational dose decisions, we also have to be careful in some of these circumstances, because things like warfarin do actually have changes in advanced kidney disease, even though they don't have any renal clearance. And so briefly, if we were looking at the apixaban option, it's 30% cleared by your kidneys and 70% cleared by your liver, with nothing theoretically coming from other things like plasma esterases and other things like that. And so where the GFR is 30 ml per minute, it's probably about 20% of normal, because the sort of standard GFR is probably about 120 ml per minute for a young person. The liver is unchanged, maybe, and we'll touch on that later in the slide. But for convenience sake, the liver is unchanged. So it's still getting this full 70% clearance. Of the remaining 30%, we need to make a change to this overall total daily dose of 10 milligrams twice a day. And so what we do here is we note that we've got about 20% of that 30% kidney function there, so kidney clearance. So we're probably getting 77.5% total clearance from the kidneys, and therefore overall total clearance is about 75%. And what that really means is the dosing interval suddenly becomes 15 milligrams per day, or 7.5 milligrams twice a day. And for a short time while we're loading this person, 10 milligrams twice a day may even still be reasonable, but then we would dose adjust.
Is that for rivaroxaban or apixaban?
This is for apixaban. Yeah.
So apixaban's 5 milligrams twice a day.
It is for chronic dosing, but for acute dosing for VTE,
okay.
10 milligrams a day for twice a day for 5 to 7 days,
yeah.
and then drop to 5.
Yeah.
But yes, otherwise it's ongoingly 5. And depending on your GFR, we often dose adjust that back to 2.5 as well. But apixaban is probably the one we have the best data for being safe in CKD, and AMH and EMIMS and all these other things have good dosing intervals for it. But this is kind of the rationale for that, whereas actually we don't have to make a lot of dosing interval changes. And in fact, we preference in our dialysis patients using apixaban now over warfarin. And there are a couple of reasons that we'll come to for that on the next slide. And in fact, so for apixaban, if your GFR is over 25, we wouldn't dose adjust it potentially. Rivaroxaban, where it's still, even though you can see that there's not a lot of difference in the renal clearance of both of those drugs, rivaroxaban still has that warning about being contraindicated below a GFR of 30. And that probably just means we haven't done enough studies in rivaroxaban. Unfortunately, the FDA doesn't mandate that people with CKD are involved in these trials, but we look at dose formulation and dosing intervals. So we're often trying to ad hoc work out how to use these drugs afterwards, which becomes a problem. And so then the question is, well, why would we not use warfarin? And why would we come through here to apixaban? Because the truth is that if I started this guy on apixaban, one of the things I would probably do down the track is a once-off 10A level, maybe a week later, to make sure that I wasn't overdosing him, or a week after my dose changed back to 5 milligrams twice a day. So he wouldn't avoid doses altogether. I would actually still therapeutically drug monitor this guy, but he doesn't need the ongoing INR levels you get with a warfarin. So warfarin in advanced CKD we used to use all the time for the very reasons that we've outlined. It's hepatically cleared. Really no significant renal clearance at all. But what we found in patients with a GFR of less than 30, and really for those who are dialysis requiring, so more of a niche group, but does extend up to that GFR less than 30, despite that, they have a lower dose requirement, they have more variability, they have increased risk of bleeding, and actually they have a reduced effect in their stroke prevention in AF relative to people who don't have CKD. On top of that, advanced CKD has this risk of this really serious complication called calciphylaxis, and warfarin increases the risk of that. And so for us, in patients with advanced CKD, it's really spurred a move over to apixaban, which doesn't have some of these other issues. And so it's very uncommon now to see a dialysis patient on warfarin. The example where they probably would be is if they've got a metallic valve. Otherwise, we would try and shift them to something else. All right. And so that kind of comes on to this other question about drug handling. So this was one of the things that really bothered me when I learned about it. So Darren and I did this paper in 2019, and one of the things that, Darren highlighted, Darren Roberts used to work here as a clinical pharmacologist and a renal physician. So one of the things about advanced CKD is that it also reduces hepatic clearance of drugs, which is really, really annoying, because it's really nice to think about these things as compartmentalized buckets. Your renal kidney function doesn't work, so renally cleared drugs are going to be altered. But also it spills over, unfortunately, to the other bucket. And so this is showing a couple of examples here where in someone who has advanced CKD in black, their dihydrocodeine clearance, which is a hepatically cleared drug, significantly increases in someone with end-stage kidney disease. And when we look over here at a whole bunch of other hepatically cleared drugs, including things that we wouldn't think would have any renal clearance at all, like midazolam, omeprazole, theophylline, as your GFR drops below 30 from normal baseline, progressively you get reduced clearance of these drugs too. And for example, for omeprazole, you can see we're down to about 25% clearance with a GFR of 30, which is fascinating on one level, but it's terrifying on another, because we don't really think about dose adjusting these medications. And it's very hard to know exactly what to do with them. So I put it in there more as to cause concern. And the other one, all right, so we'll come on to I know I'm a bit, we've got time. So we'll come back to our 67-year-old male with his type 2 diabetes. It turns out he's on metformin, a gram twice a day. He's had a bit of vascular disease that we covered before, and his GFR's now dropped to 35 mils per minute. And so the question comes, well, what do we do about that metformin? And so I often get told by the residents that metformin is nephrotoxic. Metformin's not nephrotoxic, actually. It has no negative impact on kidney function or kidney physiology, but it is renally cleared. And so as GFR drops, our ability to clear metformin, as you can see, it's actually got, from the previous slides, potential to 500 mil per minute kidney clearance. As that drops off, our ability to clear it reduces, and its half-life starts to stretch out. So over time, someone who starts on a reasonable dose of metformin, as their clearance drops, the half-life rises, and their serum levels gradually creep up over time. And this potentially becomes a problem because and sorry, I put Krebs cycle in here. I was going to get rid of it, but if you look at metformin, so it works by reducing hepatic gluconeogenesis. So that's how it reduces serum glucose, by reducing this hepatic gluconeogenesis at normal physiologic doses. And so that's its role in here. However, that leads to increased pyruvate generation, and we're kind of sort of blocking its transit across into gluconeogenesis, which is the normal role. However, as it accumulates, it also blocks the electron transport chain in the Krebs cycle. So we can't get rid of this pyruvate through the Krebs cycle. And now it ends up being driven all into lactate. And what we get is this metformin-associated lactic acidosis. And so these guys can come in with, lactate levels. The highest I've seen was 18, rip-roaringly going, very, very unwell. And it is simply this accumulation of lactate. And we can often see this with sudden changes in kidney function, particularly when people are very, very unwell. And which is why I always recommend people, if they are getting unwell or if they're becoming dehydrated, that they just need to pause their metformin until they're well again. But it can also be one of these that does gradually accumulate, as you can kind of see from this sort of slide here. As you can imagine, someone here in black who starts out on their metformin, as the half-life increases, as their clearance drops with time, they become the person on the blue line, and then they become the person on the red line. And that serum concentration starts to gradually creep up. And so what do we practically do about this? So there are a number of strategies that we can do to manage this for people, because metformin is a very good drug. And we do like to use it, and we do use it now down to a GFR of 30. And there are some people who are using it even below that with lactate monitoring. But for me, that balance of benefit versus time investment is probably not worth it at that point. But down to 30, we would still use it. And so when we're looking at something like this, where we're worried that this person's going to be creeping up into this red zone, we need to start and get out in front of that. And so what we would say is we would measure this person's GFR and be like, well, this person is at risk of metformin accumulation. And so we're going to either do one of two things. We're going to either increase the dosing interval. So in this example here, it's second daily, but for metformin, it might be we go from twice a day to once a day. And then what that does is it means this peak, we still get a bit more of a peak, but we're getting better clearance now because we've got twice the time in which to do it. The other option, as we can spread that even further, what you can see is we're essentially mimicking normal dosing by stretching it out further. And for metformin, what this means is that if we looked at someone who's getting 500 milligrams, we can also change that dose and sort of across different intervals as well to get the same average concentration like we see here, but that benefit to giving a lower dose more frequently might actually be a good way forward. And so this is an example of someone who we could dose with metformin. And if we went with the same relative dose, 1,000 milligrams a day, we would get this red line here where, our average level is probably there and thereabouts our target range. But you can see we're sort of scooting up above it at times. If we go alternate days with a bigger dose, because we're going to get a bigger dose, we get a higher peak, but we also get a lower trough. So it's swinging up and down. And this is probably less good. But if we can go a lower dose more frequently, we get a lower overall peak, but we're still running that average about the same. So dropping that dose and increasing the interval, or just dropping the dose in the first instance, is probably one of the safer ways to go. And so that kind of brings us back onto some of the take-home messages, which is, you all know this, but renal function is one of these really important things that impacts how we use drugs, and quite a large number of them as well. And it is a significant prescribing issue and a real pain, because it makes it very difficult. Many of the drugs that we would like to use, we can't, or we have to be very careful about. And so when you think about those factors, and then also the patient factors that go into some of these drug decision making, and probably most importantly, it's once we make that dosing decision that we're going to give someone apixaban or metformin or a sulfonylurea, and we've made a rational decision about how we're going to dose it, that we then think about, hey, we do need to follow this up and monitor their response. How are they going therapeutically? What are their blood sugars doing? Maybe we need to get them to more frequently monitor in the early phase until people settle in. Or if their kidney function is declining, that we're again monitoring more frequently to catch people as some of these toxicities can start to accumulate. Stop. All right, and there are some of the resources that I would routinely use. Predominantly AMH, I find very convenient to access. The renal drug database, when I'm really struggling, up to date, is an American website. It's very, very good for many, many things, but I would generally go with AMH or renal drug database. Therapeutic guidelines and AMH essentially have the same information in them. I just find AMH easier to access. And MIMS can have a great deal of detailed information, and it's readily searchable, and it's perfectly good as well. So we'll move on to the time for questions and the evaluation form.
Fantastic, Tom. That's again another excellent presentation. I feel a little overwhelmed. I think there was so much information to absorb, and I hope you've all enjoyed it. Please do put your questions in the chat function. Just whilst I've got that evaluation QR code up on the screen, if you want to take a little quick click of that. Otherwise, we will be sending it out to you in an email. I'm just going to stop sharing our screen so that we can see. I'm hoping. I'm hoping I can see the QA. Where would the QA be? Chat function down here and the QA box. Here we go. Oh, no questions. Come on, people. Help me out here.
Please repeat the resource slide.
Okay.
I can send that.
We can send that out to you, actually. There was MIMS, there was AMH was probably the most useful, therapeutic guidelines, and what was the last one? It was a renal...
This is renal drug database, which is a sort of a compendium of studies of looking at drugs in kidney disease. Because often you're kind of trying to drag together some of these sort of, as I said, the FDA unfortunately doesn't mandate that we look at this stuff. And so it's often we get these sort of smaller studies here and there, and trying to drag all that together is the renal drug database is good for that. Okay.
All right. Yeah. So I've never looked at it, so that'll be interesting. So I sort of thought I'd start this off by asking you, because it's such a lot of information really, isn't it? And suddenly halfway through I thought, oh my God, I feel a bit overwhelmed, and how am I badly treating and managing my patients with CKD out there? I hope nobody else felt that way. But I wondered, from your perspective as a renal physician, how skilled do you think GPs are in being able to manage and monitor for these issues?
I think GPs are probably very good at this, to be honest. It's one of these things where I think a sensible approach, which most doctors really have to this, is that you recognise that the GFR is reduced, and you think about the drugs that you've either prescribed or you're going to prescribe, and you make those rational dose adjustments based on something like your AMH. We don't really see outrageous prescribing for people with CKD. I think people are relatively cognizant of it. I think it's always good to remind us. The thing I remind myself is about this is that even though I feel very comfortable with drug dosing in renal disease, that's probably a little bit arrogant, because I think it's actually a lot more difficult than really we standardly understand. And so what I really take away is that when I am dosing, particularly something which is renally cleared, my key thing is to be monitoring carefully patient response. And having a low threshold to changing something or dose adjusting if needed.
And in regards to monitoring, so we're really monitoring for toxic effects. So that drug, say for example, an opiate, so increased sedation, or
and that would be a good example. So your codeine, for example, where we're gonna, talking about morphine essentially, so it's mostly renally cleared, significantly renally cleared, so that risk of accumulation and toxicity is there. So that, and often that is probably patient counselling, just you're at increased risk if you're getting more drowsy. Drop the dose back if you can, or book back in, and we'll see what we can do.
Because it is a lot of patients, actually. If I think about my patient cohort, there's a lot of people with CKD. So how often do you think a GP should be doing a medication review of their patients?
Yeah, look, it's a really good question. I mean, I think the answer is it's difficult, but I think it probably relates to how severe the CKD is. I think if you're talking about someone who's got sort of stage 2, 3A CKD, you know, they're not going to often end up with a lot of difficulty with many drugs. And so you probably, you know, maybe you could be thinking about maybe once a year or something like that going through. Or,
not more frequently?
well, not for someone who's got pretty good kidney function, but I think once you're kind of getting down to 3B and 4, you know, I'm probably thinking about, you know, quarterly or so, just having a look through, even just a mental reminder to say, am I still comfortable with everything that's on the medication list? Because I think that's where, when I find I get into difficulties with these things, it's something I prescribed years ago that is still there, and I haven't thought about it.
Yeah. Okay. Now we have a question, a couple of questions coming up. So Louise has asked, sorry I missed the beginning. If this was already covered, please don't answer. What about Prolia if the GFR is less than 30? This is a good question actually, because we have a lot of our elderly patients on denosumab.
Yes.
Yeah.
So the denosumab is... So we use denosumab for patients with advanced CKD. The thing, denosumab doesn't have a lot of renal clearance. It's being a monoclonal antibody, but what it does have is that ability to drop serum calcium, which is what we're often worried about. So for someone who's vitamin D deficient or unable to make activated vitamin D because they've got advanced CKD, there's this theoretical increased risk of that adverse effect. So it's not an absolute contraindication, but it's an area where we would be much more careful to make sure that they are vitamin D replete, and that the calcium levels are adequate. And giving that level, and then monitoring again post.
So really important to monitor the vitamin D and the calcium, serum calcium as well, or just ensure that they're taking adequate calcium.
So probably serum calcium too, because one of the difficulties with advanced CKD, depending how far along they are, is that if they're getting cholecalciferol, they might still have low serum calcium if they're unable to metabolize it to 1,25-hydroxy.
Okay. All right. What is the concern in a person with a stable GFR but increasing albuminuria and lowish sodium around 140?
So for that sort of person, increasing albuminuria suggests that they have got some defecting, probably in glomerular in the glomerular filtration barrier, which is allowing protein to come through. So depending on how much protein that is, it might have an impact in terms of deciding, drug dosing, for example, like a frusemide. But sort of overarchingly, just coming away from prescribing for a minute, that's kind of the sort of person where I think, okay, well, they might actually have glomerular disease there that we need to better manage. And so that's the sort of person where I'd start to look and see, do they have a primary or secondary glomerular problem that, in fact, at the moment, they've got a preserved GFR, but it's a great opportunity to do intervene and try and reverse some sort of process or manage their hyperfiltration if that's what's happening, to protect their kidney function going forward. But from a drug dosing perspective, if they've got a little bit of proteinuria or albuminuria, the impact on renal drug handling is going to be relatively low. It's more when they're starting to get sort of nephrotic range proteinuria that we do start to struggle. So you might see that in someone with sort of bad type 2 diabetes, for example.
I didn't know that frothy urine meant protein.
It can. So some of the proteins act like a detergent, essentially.
Right.
Yeah.
There you go. Learned something new. And I learned many new things, sorry. So Ash asks, how quick approximately should we expect the change in creatinine once AKI sets in? So you sort of had a little graph that you were talking about. Yeah.
So that initial point from where, and it's really impossible to see this in real life, but that point from where the kidney gets injured is where we see that initial rise in serum creatinine. You can be looking potentially 24 hours for a number of reasons. That's going to be that delay in accumulation of that creatinine over time, but also the time point between bleed and onset of AKI as well. So you may not see a lot of change even in the first 24 hours, but then it's going to start to ramp up depending on the severity. So the more severe the AKI, the more rapidly that creatinine is rising. Or take into account body mass and things like that.
So Ash also asks, apixaban and Xarelto both are renally excreted, 30%. So why Xarelto is contraindicated below eGFR of 30 and apixaban is not?
It's a very, very good question. Yeah. And the answer to that is that with the data that we have at the moment, the thought is that we don't have enough data to support using rivaroxaban at lower doses. We've got very, very comfortable using apixaban at lower doses. And the probable answer, trying to predict the future, is I think what we'll find is that we can use rivaroxaban at lower doses, at lower GFRs than we currently use it. And we're just going to have to wait for a bit of data to make sure that we're doing the safe thing there.
Okay.
But I would very much like to use it because I think that one of the difficulties with apixaban is it's twice daily dosing. I'm terrible at taking something, more than once a day.
Drops,
yeah, absolutely.
Yeah. Please give some tricks how to dose warfarin in dialysis and CKD patients. Well, most of them won't be on warfarin anymore,
Yeah,
we told us.
It's relatively uncommon, but for those that we do, for dialysis, for hemodialysis patients, we're actually monitoring them reasonably frequently. They'll get probably weekly INRs through the dialysis unit. In terms of dosing, I still start the same. I still start, start standard dosing. I know there's been a lot of variances there now, but I'm start at 5 and then measure the INR after 2 to 3 days, and then I just dose adjust from there. One of the difficulties that we really do find is that there's huge variability in those INRs in people who are seemingly compliant, where you make a small dose adjustment and suddenly the INR tanks from being super therapeutic, and it's really difficult. So I essentially what I do is I try and make small changes, and I try not to over respond. So if the INR is a little bit too high, I will simply repeat it and then see where we go rather than dose adjusting, because otherwise you do find yourself chasing your tail with those INRs.
And I was just thinking of a particular patient. I've got a patient who's very obese, so her GFR would be which way? Her GFR is overestimated.
So it will be underestimated by eGFR and overestimated by the Cockcroft-Gault equation.
Right.
So, and it's fascinating with significant obesity. And GFR. So I've had a very difficult patient recently, a very nice patient, very difficult case. Someone who had acute interstitial nephritis. She's probably about 100 kilos, and we didn't have baseline kidney function because she's 30. She's previously very well. And so we thought we treated her well, but we couldn't get her GFR up above 60. So she's running a creatinine of about 110. And I was really worried because we had actually previously weaned off her medication a month or so prior, and she'd reflared. Partly weaned her medication and she'd flared. So I wasn't sure if we were still under treating her. So anyway, I ended up doing a 24-hour urine creatinine clearance on her. And it turns out her GFR is probably about 130.
Right.
So it sometimes can be really, really difficult.
Deceptive.
Yeah.
Okay. So we've also got another question about warfarin. Does warfarin get filtered by hemodialysis?
No, it doesn't, and that's partly it's a number of different reasons for that. But one is it's got this really huge volume of distribution, so we can only really efficiently dialyze things that are present in the bloodstream, or can rapidly redistribute into it. And warfarin, partly because it has this big volume of distribution, and partly because its effect is sort of long-lasting beyond the dose. So because you're interfering with the coagulation factor production, actually you're seeing that effect sort of down the track. And so we don't really see a lot of differences there. Some people think that one of the reasons we struggle with warfarin on dialysis is that the thing that hemodialysis patients have that none of the rest of us do is that 3 times a week for about 4 or 5 hours a session, their blood is exposed to a foreign membrane, the dialysis membrane. And so we might start to see coagulation cascades setting up on that loss or, partial loss of coagulation factors, and that may mess around with warfarin's effect and partly explain some of these difficulties, but the real answer is we don't know.
Okay. All right. I'm not quite sure about the next question. Any particular drugs, if on an ARB, metformin and statin on the person with increased albuminuria but not tolerant of Kendra? What's Kendra?
I'm not sure the drug, but
Being a bit daft. What's Kendra? Whoever asked that question.
brand name is.
Maybe related to that, I was going to ask about polypharmacy. So a lot of our patients are. What's Kendra?
It's finerenone. I wondered if that would be the case. Yeah, I do that, and then
So a lot of our patients are on multiple drugs. Got CKD. So is the how does that all interplay? Sort of its impact on the kidney function? Do we have to be more cautious?
Yeah.
Should we be thinking about deprescribing a bit more? What are your thoughts around polypharmacy and CKD?
It's one of these difficult ones because it's almost a necessity for most of our patients. For deprescribing, I would like to be better at this too, but I try and sort of consciously think to do it. Maybe every second time I see someone, I run through that medications very briefly and think, can I get rid of any of these things?
Yeah.
Because I think if we can deprescribe stuff that maybe not necessarily anymore, even just try to get things off. I think one of the hardest things is getting people off PPIs. I seem to get quite a lot of rebound.
So we should be careful about PPIs. I just learned that.
Potentially, yeah. And I think it's, if we can get people, the more we can get people off these things, the more compliant they'll be with the stuff they truly do need. To come back to the question about the Kendra, which is
what's Kendra again? Just explain.
It's finerenone, so it's one of the new mineralocorticoid inhibitors like spironolactone, but without the steroid sides. So you shouldn't get the gynecomastia and things like that. And at the moment, it's only PBS approved for diabetic nephropathy, where you're already on an ACE inhibitor. And you may also need, I can't remember now, but you may also need to be on an SGLT2 inhibitor as well. So there's good data that suggests that it will reduce your risk of progression if you are still proteinuria with diabetic kidney disease, and presumptively with other things. I mean, you can use spironolactone, but finerenone is probably, especially for young people, a nicer thing to take. In terms of where you escalate, it's really difficult because if you've already got someone on an ACE or an ARB, you've already got them on an SGLT2 inhibitor, and you've got them on finerenone. We actually don't have a lot of additional targeted therapy at this point. There is some data coming out potentially around GLP-1 agonists in that setting for someone who's diabetic, and that person was on metformin. But we don't really have enough data now to say that would actually be the next best step. But it's going to be about risk factor reduction, managing their blood pressure, good glycemic control.
Okay. So somebody asks, which is a slightly unrelated question, persistent hematuria in older patients on long-term thinners or DOACs, would you almost always send cystoscopy after appropriate workup? Well, that's going to roll into our urology kidney health talk next time, but do you want to comment on that?
Absolutely. So I think we do see this quite a bit. So in some ways, I think, so one of the things about hematuria, one of the things about bleeding with any anticoagulant is anticoagulants, unless they're outrageously super therapeutic, won't be causing spontaneous bleeding. So there's a defect somewhere. And the question is, where is that defect that's making it more noticeable? And so the persistent hematuria, I'm not sure if it's macro or microscopic. If it's macroscopic hematuria, I'm going to be, especially an older person, I'm going to be thinking they're going to have some sort of urothelial problem. So they're probably someone who's going to need some imaging, urinary cytology, and probably a scope, cystoscopy. It is potentially that it's coming from the glomerulus, and so we would have to think about that side of things too. But in that demographic, it's going to be someone who's going to need a scope probably.
Okay.
Yeah.
All right. Next one is, does an ARB help just as good as an ACE in reducing proteinuria?
The data that we have suggests they're probably just as good as each other.
You answered that at the last webinar. And are there any, this one's a good one. I was actually going to ask this question as well because I had to get in my thing about the Krebs cycle because I did a bit of YouTubing about the Krebs cycle. Anyway, so this person's asking about over-the-counter medications, and I was going to ask about, a lot of people taking vitamins, supplements. What are our considerations with you know, those things, and toxicity when somebody has CKD. Coenzyme Q, I got that from the Krebs cycle.
Yeah. Oh, so much PTSD, right?
Yeah.
So it's actually a difficult question to answer. So in terms of over-the-counter drugs, I mean, things like codeine is probably the thing that comes to the top of the list. And then the other side of it is then moving into the sort of the herbal things, and we don't really know how these are being handled. And then we also don't know what their sort of therapeutic index is. And we're really working in this very, very grey area where it's hard to know what's the right thing to do. I actually don't know the answer to glucosamine. I'm not sure how I would suggest that. I think realistically, to answer that question, I'd have to go to the literature and see if we have any actual studies looking at clearance. And I worry that we don't, because there's obviously no incentive to do so.
So, I mean, would a sensible approach, I mean, my approach would probably be to say to somebody with kidney disease, look, if there's no clear reason for taking it, probably shouldn't be taking it at all, and that includes supplements.
I think so. I think also for most supplements, you're talking about things that have very, very limited or no evidence for effect, and then they're probably $30 a bottle every month, and so
they're expensive.
So the benefit to cost is probably relatively low for stock, and then if you put them to that, we don't know how they're renally handled. Anyone with sort of stage 4 CKD or above, I'd probably just say don't worry about it. Yeah.
Okay, fantastic. Look, I think that's bringing us to the end of our questions. We're just on 8:45, so we've done really well timing-wise. Again, thank you so much, Tom, for taking the time to prepare this webinar series. And thank you, all our participants, for coming along and asking all your questions. I hope you've learned an enormous amount. I know I have. So good evening, everybody, and I hope you've enjoyed it. Please remember to do the evaluation feedback. It helps us with planning for our next lot of education sessions. Take care, everybody. Good night.
Thank you for coming.